We have a great panel. We have an outstanding moderator, Dr. Marcus Sciadini from Shock Trauma. He's been faculty here before. And what his session today is going to be My Fracture Fell Apart, When to Hold Them, When to Fold Them. Marcus, thank you very much. Pleasure.
Thanks, everybody. I know it's late in the day. Tension starts to wane. We'll try to keep it interesting. This is all case-based stuff. And I just want to thank Drs. Raymond and Kazanjian for inviting me again this year, and glad to see it in person. Have a great panel with hopefully Dr. Archdeacon, who's the professor and chair at University of Cincinnati, who's going to be joining us remotely. And then we have Dr. Ahmed from the Rothman Institute in Orlando, Drew Brady from Christiana up in Delaware, and David Galos from right here at Temple. So got a great group. We've got some good cases to get through. And so to that end, we'll go ahead and get started. I think the key to this session really is just remember, and you guys are all aware, we learn a lot more from the things that go badly than the things that go well. And I think provides us an opportunity to kind of come up with some interesting solutions to difficult problems and really think on our feet. So this first case is one of mine. This was a 44-year-old homeless guy that came in with a, I don't know how to make that go away. Came in with an open extra-articular supracondylar humerus fracture. So a fairly straightforward fracture, not a terrible open wound. And he underwent single-stage irrigation debridement and open reduction internal fixation with this sort of pre-contoured locking distal humerus plate. So 4 months post-op, he came in with these early signs of failure. He had some resorption at his fracture site, had ongoing pain, some subjective instability. What do you guys do at this point?
So at this point, you're really highly concerned for infection. So send an ESR CRP and talk to him about how he's going to need another surgery, and go from there.
Yeah, I mean, I think this is clearly already, the cat's out of the bag here, right? You got to do something with this. So we did all that, and he was scheduled for a non-union repair, and then 8 months later, he shows up looking like this. So now what, David?
What was the result of the labs?
His labs were actually normal. There was no clinical signs of infection, no laboratory evidence of infection. Have a lot more pain and instability now.
Yeah. He's obviously very uncomfortable. He had a lot of instability, you said. So, I mean, I would repeat the labs again. 8 months out, this is obviously clearly failed. You have broken hardware. You have bony, overgrowth everywhere. Probably have some sort of pseudocapsule going on as well. So, I mean, at the very least, you'd want to take out the hardware and at some point figure out how to get this to heal. It might not be a bad idea to go in there first, do an IND, take some cultures, take a bone biopsy, see if anything's, brewing in there, and come back in a staged fashion once your cultures come back or your bone biopsy comes back to do, if it's truly not infected, to do a bone grafting procedure and maybe think about adjusting your fixation strategy for this, maybe making something a little bit longer, spreading out your fixation a little bit, even dual plating it. But if it is infected, then you have some sort of bone void now that you got to deal with. Potentially either doing a shortening of the humerus, which can oftentimes be tolerated to a certain level, or doing something to reestablish that defect that you have now.
What do you think, Drew? Does this have to be staged?
Yeah, I think it needs an operation. Whether the patient's going to show up for the operation or not is another thing.
Sure.
But I think it needs an operation, and in my mind, it needs at least 2 operations, because I think the next operation is just kind of getting your bearings, trying to set a baseline and finding out where you're working from. So you got to get some good cultures. It looks like he wants to try to heal something because there might be some callus sort of in there. So if it's not an infection, and so oftentimes these things, you get in there and you think it's going to be infected and it's not. So you think you're a win. But I think it's definitely a staged operation and a definite operative problem. Oh, sorry.
Yeah, and I go back and forth. I think, with the non-unions, I think they can often, mimic an infection just based on the chronicity of it. You get that pseudarthrosis, you get that resorption. And so unless I've got markers that are elevated or clear clinical evidence of infection, I tend to not necessarily stage them. But obviously, if I open and find pus, that's a different story. So we kind of talked about all that. His markers were still normal, clinically still relatively benign, at least from an infection standpoint. And so we did this in a single stage. But obviously it's kind of a mess in there, and it was so much scarring and reactive sort of dysfunctional bone, really hard to assess the alignment intraoperatively. And so did a little bit of shortening, kind of got things what looked like lined up, and then just put a small plate on so I can get some intraop x-rays and sort of assess whether I was even in the ballpark, because the anatomy was really hard to address. And this sort of confirmed that he was reasonably well lined up there. And so we did dual plate him. The nice thing that sort of reactive bone and cavitary bone defect did for us is gave us a great kind of canoe into which to place the graft. And so you can see intraoperatively here, this is, one of these plates is really on the reactive bone with screws sort of traversing that kind of bony defect, which we then filled with graft. And so this was him at 10 months, and this was him at 15 months post-op. So really consolidated well. We took intraoperative cultures that didn't grow anything, and if they had, we would have just treated it without feeling the need to go in and obviously yank everything out. But I think the deformity and the complexity of the sort of failure sort of offered an opportunity to come up with something a little bit different.
Yeah, I think that looks great. I've had these where you go and you had that first little intraoperative plate on to take that intraoperative x-ray. And it looks reasonably well aligned, but I've found that sometimes I'm unable to compress through that enough so that you make it look good for a couple months, and then it just sort of slowly starts resorbing. So that looks really good. And it looks like you were able to get a lag screw across a relatively transverse fracture.
Yeah, I think the lag screw was, that reactive bone really gave us an opportunity to get some compression, whereas longitudinal compression wasn't really going to be a great option. And then the biology of just packing the graft in there.
Can you discuss your management of the radial nerve and the bone graft choice?
Sure. Yeah. So I'm a kind of old school posterior crest bone graft person unless there's reasons not to. So he was lateral position, and the graft was taken from the posterior crest, obviously after exposure and convincing myself there wasn't pus in there. Cancellous, yeah, just cancellous, and no allograft as I recall, because you get a fair amount of volume from the posterior crest, especially in young, healthy folks. And the radial nerve was probably the hardest part of the case, was just dissecting it out from all that reactive bone and scar tissue, and getting it mobilized and protecting it.
Did it still work the whole time?
Yeah. Yeah. Awesome. All right, Arch, you seeing the screen?
I do. Can you hear me?
Yeah, I can hear you. I can drive the slides for you.
Okay. Well, it's a 22-year-old guy. He was crushed by his horse. Go ahead. He's fairly tough. He's not much of a complainer. He presents hemodynamically stable. And there's his pelvic ring at the presentation. Now, I will say that this case is older, and this was at a time when binders were not necessarily put on right away in the SRU or the ED. They were not put on in the field for sure. And in a patient who was hemodynamically stable, no one probably would have considered putting a binder on it. But this is where he's at. Thoughts, questions, comments?
So he looks like in the front, kind of straightforward APC injury, but in the back, it looks like he's got a little bit of a sacral fracture, not just an SI joint injury there on the left. Is that correct?
I think so. That's sort of how I interpreted it. So from my perspective, I guess one of the things that in my mind is this injury unilateral, or is it both hemipelvi that are involved? And, you know, I sort of do the same exercise that most people do. I kind of mentally draw lines. I draw a plumb line down the spinous processes in my head, and then I sort of make perpendiculars to that plumb line at the iliac crest, at the L5, the S1 vertebral end plate, then kind of across the sciatic notch, across the dome of the acetabulum, the superior ramus, the ischium. And so in my mind, it looks to me that the right hemipelvis is externally rotated a little bit, perhaps flexed up a little bit. And so obviously there's diastasis on the left sacroiliac joint, and there's diastasis at the symphysis. So in my mind, this is potentially a sort of both hemipelvis have some instability to them. There's an inlet view, outlet view. So I guess one of my questions is, well, there you go. Thoughts on injury pattern and treatment plan. Do you want me just to talk through what I did, or do you want other people to weigh in?
What do you guys think? We can kind of go through it, especially when you don't have the benefit of being in the room with us. You are in spirit.
In spirit. So this was before, you know, I personally have become a fan of the intraoperative examination under anesthesia, and I got into a pretty fierce argument last week with someone about this who is adamantly opposed to that, and I don't understand why, because I approach it as just learning more about the injury, you know, than what I learned from a static film. Now, I do think there's probably some debate whether or not you need to take someone to surgery. You know, if you're not thinking they need surgery, they take them just to examine them may not be for everybody. But once you're in the OR, I think examining under anesthesia can be helpful to get more information and get a better understanding of the pathology and the instability. Now, this was at a time when I didn't do that, and at the time I felt this was a unilateral injury, and you can see we did an open reduction internal fixation of the symphysis, and we put 2 sacroiliac screws. I think that they're in 2 different corridors. I think it's an S1 and an S2. Mm-hmm. Any critique on the reduction, fixation?
I mean, I think it looks pretty good. I think, you know, we've gotten much more fast and loose about going transiliac with our posterior fixation. And I think that's warranted for a number of reasons. Certainly, if you've got a comminuted sacral fracture, it gives you a heck of a lot better fixation than a standard SI screw. And even if you don't, it still gives you better fixation. And it also may address the occult contralateral injury that you didn't realize was there.
I would agree with that. I like using the transiliac or transsacral screws for that reason too, but I'd have to say that occasionally I've seen that occult fracture become less occult as you put the screw in. It kind of gaps open the SI joint. But once you're kind of there and you have the screw in and it's at least stabilized in that position, I kind of tend to leave it there. But, you know, I've had that happen before.
I'm not a huge pelvic ring fixer, so I'm not as facile with the transiliac transsacral screws. Certainly if there's a big S1 or S2 corridor, I have no problem putting them in. And I think these corridors would allow for that. But, you know, if this is greater than 10 years ago, I certainly wasn't going to be doing them at that point. And just a question to throw out to everybody who does these is if you have an injury on the contralateral side, I mean, when I think about orthopedics and getting fractures to heal, I think about compression first. And I want to get bones and joints as close as possible and hold them there until they heal. It's counterintuitive to me that a transiliac transsacral screw coming from the left side is going to adequately fixate and compress a screw on the opposite side when you've got threads that are going across your fracture site.
Yeah, no, I think you're absolutely right. And I think, you know, for me, if I if I've defined a bilateral injury that needs compression from both sides, then, it gets a little more complicated in the planning. Ideally, you have some safe corridors at more than one level, and then it's, oftentimes a standard SI screw from either side at S1, and then get your compression at S1, and then a transiliac screw at S2 from whichever side makes the most sense. But not everybody's anatomy gives you that opportunity, so you have to come up with other sort of inventive ways of accomplishing the same thing.
Yeah, I kind of use the transsacral screw as almost like a derotational or a neutralization type screw. I agree with Dr. Sciadini about using two independent SI screws if you have a known injury bilaterally to kind of get your compression, try to be perpendicular either to the SI joint or to the sacral fracture, and then use that transsacral screw just a way to control rotation, just kind of neutralize any of the additional rotational forces that the sacrum might see. But I agree, using that as a standalone compressive force is not very helpful sometimes, especially in the SI joint.
So, Marcus, you guys hit on a lot of the things that I was hoping we might touch on. So this was done at a time where I did not use an EUA. I would use an EUA now. The reason for that is to identify that occult sort of bilateral injury, because I didn't think that there was a right side injury, and maybe there wasn't, but as we move forward, we'll come back to that. And you can see we got, go ahead and back up one for me.
Sorry.
Back up one more. So you can see there was sort of a crescent type injury, sacroiliac fracture, as well as the diastasis and things. And then I think the thing you guys touched on is really one of the reasons I wanted to put this case in, is that at the time there wasn't a lot of talk about transiliac screws, and I certainly didn't use them very often until probably 12 or 13 years ago. And this case is from 2008, so it's 14 years ago. So that's probably just when I started doing that. And for me, it was really for comminuted type 2 sacral fractures. And I didn't really start doing it. But I think, I don't remember if it was Marcus or someone else who said it, that I do think it gives you a lot more stability when you're dealing with an unstable sacroiliac joint. It's one thing if it's a AP2 injury and the joint's gapped open, sort of anterior, and you just want to put a sacroiliac screw in. I think it's a different thing when the joint is completely unstable and then all the load is being transmitted through those screws into the body. So if the screw goes to the opposite side, it creates a very stiff construct with a short moment arm at the side of the injury. So, I kind of felt like that was probably an opportunity to make this better. And then, as was mentioned, if they did have an unstable right-sided injury, I would personally fix that first. I'd put a sacroiliac screw in that side to hold that joint stable and make a solid post to do the rest of the reduction against, and then address the rest of it as was stated. And if you go forward and you look at this is what happened at 4 weeks. The other element I want to bring up is, I don't know if this guy had a bilateral injury, but my guess is he probably did, because he failed pretty quickly. Granted, my screws were not transiliac, and you could argue the reduction wasn't perfect, although I think it was pretty close. And this is a guy that if in my mind he was a left hemipelvis only, I'd let him foot weight bear on the right and foot flat weight bear on the left. But he failed pretty quickly. Now, he's a tough guy, he's a bull rider and stuff like that, but even so, I wonder if I missed an occult injury on the opposite side, and if I'd have had more stability across the posterior ring, if that would have protected him.
But your failure mode doesn't really suggest right-sided injury. And I would argue that this is a failure of posterior fixation, and going transiliac and transsacral would have probably obviated this problem. But the other thing, I've gotten actually more conservative with my weight bearing in these. So even if it's a unilateral injury, I used to, I'd do the same thing and let them weight bear as tolerated on that right side. And then now I let them stand pivot transfer on the uninjured side early and non-weight bearing on the other side, because I feel like too much load gets transmitted through that ring to your unstable fixed side to let them weight bear immediately. And I feel like the consequences of it are pretty impressive, right? When you have to revise one of these late, it's a big problem. So I just
So Marcus, I agree with you. I do the same kind of thing, but to my mind, you know, the more unstable the ring is in more locations, the more likely it is to stress your fixation.
Sure.
So I recognize that he doesn't have gapping or anything like that, but he had his vertical height of his two rami at the initial injury wasn't the same, and I'm not confident that there wasn't some motion in the right hemipelvis. So the other thing I would do at this point is I would keep this guy in a wheelchair now. With that left hemipelvis as unstable as it was, he'd get transiliac screws, the plate in the front, and he'd be in a wheelchair for probably 5 or 6 weeks, just because of these kind of failures that I've had.
So this is sort of a little bit out of the scope, but just a quick question for me. How do you get the person out of the hospital if you say they can't walk?
They end up going to, subacute rehab, probably.
But if they're a
unless
young
they've got
person,
really good
they
family
can manage a
support.
wheelchair and do slide transfers and things like that. So I'd say if they're, a little less mobile, but if this is an isolated injury, I have a fair number of people that can slide transfer in and out of their car and things like that.
We don't got that in Delaware. If
but
can't
Mike,
walk,
if you-
you're staying in the hospital for 6 months.
Yeah. If you look at this inlet though, right, you translated posteriorly on that injured side. And again, because you were doing standard SI screws with sort of a P to A trajectory, you could imagine transiliac trajectory for your screws would have sort of counteracted this displacement better as well.
Absolutely. I mean, this is a failure in many areas: fixation, judgment, probably examination and presentation, not understanding the pathology. And then he was a little aggressive in his weight bearing, but still, I didn't really protect him that much.
So you think had you done an EUA that you'd have seen that he would have gapped on the right side?
I don't know if I would or I wouldn't have, but when I have a failure and I look back, I'm like, okay, what did I do wrong, or what could I have done better? And I've certainly had injuries that I've identified that I did not anticipate now, because I'm much more aggressive about looking at them. And I don't know who mentioned it, but it's like that LC3-like injury pattern where, this left side's unstable, the right side looks good, and all of a sudden, it gaps open at some point. So I'm much more aggressive looking for those subtle injuries. And if you find it, then I'd be more inclined to fix it. So I can't tell that person had this or this person had that, but it makes me wonder if there was more instability. And then 2, a fixation probably wasn't stout enough, and 3, I probably had him too aggressive on his weight bearing. Those are the things that I kind of wanted to bring up. So this guy was in, I think it was 2008, so 14 years ago. I'm much more aggressive with the transiliac screws, protected weight bearing, and looking for other occult injuries would be my personal try to learn from this case takeaways.
Mike, do you remember what you did to revise him? Because you don't have
Yeah, he told me he didn't have time to get fixed because he was missing a rodeo circuit, and I never saw him again.
Awesome.
Steve,
Yep.
you pointed out that there was some element of crescent-type fracture on the left. There was an iliac fracture on the left. We didn't see the pre-op CTs, but
I think we're going the wrong way.
it's possible that part of the loss of fixation was iliac on the left side.
Yeah, I mean, potentially, his screw path here, he's capturing the intact part of the ilium, but it's adjacent to that very small crescent fracture in the back, and it could have failed through there for sure. But I think, I don't think sacroiliac fixation per se is the wrong thing for this. I think maybe just the orientation of the screw and the length of the screw. Yeah.
Based on the fracture.
Yep, absolutely.
I think you have to be pretty critical of these screws, and this one clearly wasn't done very well.
All right, any other questions, comments? All right, third case here is relatively recent. Still a little post-traumatic stress from it, but this was a 19-year-old young man, BMI of 54, had a isolated right femoral shaft fracture, closed. And just based on these injury films, I'd ask if anybody sees any concerns right off the bat. Big kid. Small femur, right? His intramedullary canal is, I think, measured like 7, maybe 8 millimeters. So there was concern with what size nail we'd be able to get in him.
Those are all the films you have for pre-op?
Yeah, I believe, I mean, for the sake of this discussion, yeah.
I mean, do we have to be concerned just about the neck, because you can't see that head? very
No,
much?
this is,
All
there's no hidden tigers here. This
Yeah.
is just the straightforward sort of femoral shaft in a really big kid. This is just him in traction, so, pretty reducible. Because of his body habitus and size, the decision was made to go retrograde, even though it's,
No
a
brainer.
little closer to the hip than the knee, but definitely a retrogradable fracture.
You worried about the gapping and just in traction? 'Cause that's a lot of gapping at the fracture site when you put some traction on them.
Yeah, I don't have an explanation for that, because we usually don't see that, particularly in
Yeah.
young, healthy folks, and especially big ones, their quads, you can pull on them and they don't budge.
Right, it tells
so-
you it's high energy. I mean,
Yeah, yeah. So, yeah, the biggest concern was really the diameter of his femur, and these were the steps taken. It was actually one of my partners took care of him initially, and I think, for the transverse femur fracture, in our place, we've got fellows and residents and, tons of hands on deck, so we're not using fracture tables for femurs, we're using hands and manual traction. So they tend to be done, antegrade nails are done lateral on an OSI table, retrograde supine on an OSI table, but it's all manual traction, manual reduction techniques, and pretty quick to go to the shank pins in the two fragments for direct manipulation of the fracture to get the reduction. You can pass the ball tip guide wire past the shank pins, even if they're bicortical, most of the time. But here's just the steps that we're taking to get him reduced, and this is what he ended up with, I think, with a well-reduced femur, but only a 9mm nail. And so 9 days post-op, he falls down.
Hey, Marcus,
Yeah,
can you back up to your shank pins real quick?
yep.
I love that trick. Do you ever do that with, use the femoral distractor instead of your hands?
I don't, because what happens with the femoral distractor is you end up making it look good in one plane and not in the other, right? So it'll end up flexing or extending in the sagittal plane, and trying to correct that with the femoral distractor I find to be very difficult. What I do with this is I almost do it blind, where I'm like, it's a feel thing. You can kind of feel the ends of the bones sort of on each other, and then I'll tell the person driving the guide wire, I'll be like, okay, try to pass it now, and they'll either pass out of the canal, in the canal, or they'll hit a cortex, right? And if they hit a cortex, then I say just incrementally rotate that bent guide wire, a fraction of a turn, and see if you can't drive it into the canal. And oftentimes you can do it without even using fluoro, just by going tactile, especially in these transverse patterns like this.
So I have the exact opposite experience. I find the femoral distractor super helpful, especially in these morbidly obese patients. And the way I do it is that top pin, the proximal one, is like my pivot point, and I put the pins fairly close to the fracture, and then put the long handle on the distractor, and it serves essentially like you're translating. I think of it like a young Bluth clamp screwed in, where you can translate in two planes, compress or distract. And so I personally find it super easy, but I can understand how if you get too much distraction, it can create deformity. But I have a patient that was 700 pounds. I did a similar femur thing, and that's always been my go-to for those kind of bigger patients and things like that. But
No, I think the femoral distractor is super helpful, and I think the way to get good at it is to get good at it and use it all the time, even when you don't need it. And I tend to be a fairly impatient person, so I don't want to mess around with it, so I'm not very facile with it. So here he is, and here he is. So I'd kind of put it up to the panel. What do you do with this? How do you get that bent nail out of this femur?
You're not going to straighten it out. The metal cutting burrs, that's what you got to go through at first, and you got to open it up to do it.
Yeah, I mean, so I talked to some of my partners. One was like, "Yeah, I had this happen, and I straightened the femur in the nail. It's like it was really hard." I'm like, "Yeah, I bet." And I was like, "Okay, I'll try it." And I think maybe in somebody who's not this big, maybe it's possible, but you can't really apply any direct re-deforming load to his leg because the soft tissue envelope is so wide, right? So we tried that a little bit, and that didn't really work. And then somebody else had told me, oh, if you get your extractor on there and you just hit it hard enough, it'll straighten as it comes out of the femur. I'm like, okay, well, I tried to straighten it, that didn't work. So I tried whaling on it, and that didn't really work either, because what ended up happening was it started to back out, and then I could see where it was basically going to just comminute the entire distal femur, because the effective diameter of this nail is now from here to here, right?
Yeah.
So that was clearly not a good plan. But we did have the Midas in the room, and so what we did is open the fracture site and basically just notched the nail on the concave side enough to weaken it so that it would straighten, but didn't cut it in half. So I was able to get it out in one piece, which I felt was a victory, because I think it would have been a bit of a struggle to get this sort of residual portion of this 9mm nail out of his proximal femur in a thigh wound that was elbow deep, just to get there.
So did you guys write that up? Because I haven't seen that, but that makes
I did. It's
perfect
just
sense.
it's been like within the last month. So, but
That's a nice look.
this was just kind of
Because I would
the
just cut it, and then you got to dig out a,
yeah.
Yeah, I've had to do that before, and I cut the whole thing all the way through, and it's a nightmare getting that distal part out. And the way I ended up having to do it was use the solid nail extractor to then screw into that part of the nail that's.
But it's hard, in a
exposed.
9mm nail too. I'm not even sure they make conicals small enough diameter to fit into the mid portion of a
Yeah.
9mm nail, right? Then you're talking about those, trying to jam up a bunch of
Multiple
ball
layers.
Yeah,
tips
that
and
thing.
pull them.
Yeah.
So, yeah, I think it worked here. I don't know if I just got lucky, because I was really surprised that it didn't just break in half. But I guess if you just kind of do it the one time and you don't start bending it back and forth and fatigue it, you can get it out in one piece. So that really helped us. And then I just decided, and we were able to ream him up to a 10 or to 11.5 to put in a 10mm nail. And that probably would have been more than adequate, but I was like, I'm not gonna take chances. So we, after we nailed him, we added a plate, belt and suspenders, so that I wouldn't have to sweat it. And even though this is a relatively prominent extramedullary construct for him, I don't think he's gonna feel it.
you let him walk out on that now?
Yeah, I feel like you kind of have to, right? It's a femur, he's 19. What he needs more than anything is to walk on this, and especially since that fracture site's had to be opened now. It's one of the things I think some of the studies have shown, like the patients that have the ipsilateral pilons and plateaus where they can't weight bear are the ones that get the femoral non-unions and delayed unions. So. All right. Any questions, comments on that one? All right, David, you're up.
Oh, sure. You want me to come out there?
Sure. You can drive there.
Okay. Well, this is a little wordier than the other one, so my apologies. This is a 72-year-old female with a syncopal fall, injuring her left ankle. She has a bunch of medical problems, but most pertinent one is this: she has neuropathy from some unknown etiology with almost no sensation in her ankle. She had a closed injury, but had some medial blistering on her ankle, and some skin tinting. She was motor intact, but again, no sensation. And so kind of this was her ankle.
Yeah, so it looks like she's got at least a bimal. Probably looks like there's a little fracture in the posterior malleolus too. Ankle's obviously displaced and dislocated. So that definitely needs a urgent reduction and new x-rays after splint in the ER.
Yeah.
Well, that looks like the reduction right there, right? Because it's in splint already?
I think she came in with this from it was like an
Okay.
EMS type splint. So she was close reduced. Looks a little better now. So she was a little delirious, we kept on opening up her splint to check her wounds. She was well reduced, but we got a CT scan to evaluate for that little posterior mal, and then she had this.
Yeah, so that ankle's definitely dislocated out the back through that tiniest of medial or posterior malpieces. And this is where you know that neuropathy is really playing a big part in your injury and the way you're going to treat it, that you can't treat this just like a regular ankle fracture. I would definitely not leave her like that, and I know the skin's not great, and so at this point usually I would pull the trigger for a hindfoot nail to fix this.
Yeah, I think that's a underutilized, even from the get-go. In the diabetics with bad neuropathy, first off, you can fix them, make them look perfect. You can over-fix them with all kinds of transsyndesmotic locking fixation, and they will still humble you by coming back looking like this in short order, because the neuropathy is just a game changer. And they tend to be fairly low demand. They tend to be pretty tolerant of that loss of motion, and I think it works really well for these really high-risk patients.
Yeah, I would agree. She came in, I think it was around Christmas time, so she got re-reduced, and then she went to the OR, and they opted for fixation. So, looks reasonable. She came to the office. She had a medial eschar. Her incisions were healing reasonably well, but she came to the office in 2 weeks, looking like that.
Yeah, I think after that, I think the immediate hindfoot fusion nail sounds interesting. I've not yet pulled the trigger on many patients on that. There's a few that are there, but I think after seeing that CT scan, you definitely have to be concerned about it. But what I probably would have done is fixed it like it was fixed initially, but augmented it with the next fix and given it some time.
And I think also, putting as many screws as you can through that plate across the syndesmosis into the tibia, just I think is hugely helpful too.
Yep.
So she was tenting again. So we had her admitted and took her to the OR the next day for exactly what you guys were talking about. So we left the plate on because we didn't really want to mess with that lateral wound if we didn't need to. It wasn't causing us any trouble, but just went for a hindfoot nail. Took out the medial screws just because they were in the way. But I agree that I think that it is a really good implant, especially in the diabetic neuropathic patients. We get like a lot of open fractures medially in that patient population. They do very poorly, so if you can avoid putting any fixation there, this is a nice option to kind of keep things out of the way of any contamination.
Yeah, and I think too, we have a lot of controversy amongst our group. A lot of us will do this, but we do it a little bit differently. For me, particularly, it's always in the high-risk patient, right? They're either vasculopathic, neuropathic, diabetic, obese, all of the above, elderly, open, what have you. And if it's a closed injury like this, then I get the reduction, I put the nail up, and I'll prepare the joint at all. Yeah. And I plan to take the rod out at some point, because I've had, ones where they fail because they still have, they get hardware failure that can be problematic. Right. And to avoid that, I'll take the nails out. If they're open, like that big medial wound, open fracture dislocation, then I'll prepare the joint, at least the ankle. But to me, the whole point is to not make wounds in the zone of injury, which you kind of need to do to take the joint down. So I don't do that, but I have a partner who says, I always take the joint down.
I don't take the joint down. I didn't take the joint down here.
Yeah.
I let them walk on it right away. I mean, I think the benefit is, especially in the geriatric population, it's hard for them to deal with a cast, and any amount of time that they can't be ambulating is troublesome. And so if you can get them to walk on it early, I have no problems with that.
I mean, I think the other key, like you did here, is you went long post-isthmic. The short nails where you can target the proximal locking bolts, I think, are too short, and especially the diabetics, they'll fail those just like the original construct because they don't have that isthmic fit.
Yeah, they'll windshield wiper in there, so I tend to try to go super isthmal. think, 240, 270, 300-ish length sometimes, depending on the length of the tibia.
You're doing that with a standard hind-foot fusion nail, or you're using another nail for a different purpose?
It's a standard hindfoot fusion nail. This one, I mean,
They just tend not to be long enough for me.
so
No,
it
they
depends
have
on
them.
the,
Most
depends
of them
on the
do
company.
have
So this happened to be, I don't necessarily want to get the proprietary stuff, but this happened to be a biomet nail. They tend to go up to 300. It's just their standard
Yeah,
Phoenix nail.
I think most of them
Other
will have
other
something.
companies have long ones too, but I know the Synthes one, for instance, is not very long.
When I learned this technique as a resident with Ken Johnson at Vanderbilt, there were no hindfoot fusion nails, and he just used retrograde femoral nails.
Yep.
Because, and his, well, actually, that's not true. There were hindfoot fusion nails, but they were all short, and they were all targeted, and they were really short.
Right.
And he was like, it doesn't work because you don't get past the isthmus.
You get a guy that, I mean, I needed 420 at one point, so I mean, I just retrograde femoral nail and put that up there.
So like you said,
Marcus, does
Yeah.
anybody, any of the group consider using fibular nails for these neuropathic dislocations, particularly one like this one that falls into valgus? I don't know if anybody knows Tim White from Edinburgh, but he's been using fibular nails for some of these complex ankle fracture dislocations, having good luck. I know Roy Sanders has been talking about it more recently, and Hassan Mir. Any of the other have any opportunity? I personally have only done it like once or twice, but it appeals to me that it's an intramedullary construct, so it's minimally invasive, and the person, you want to minimize the wounds. It provides a very stout resistance to lateral translation in that valgus, but I have limited personal experience.
I don't know if I would, I mean, I think it sounds interesting to me, but I also don't know if I buy that it's better than a heavy-duty lateral plate with 4 transdesmotic screws through it, in terms of being providing a lateral post, right?
Yeah, I think the only advantage over that construct would be the ability to place it
Yep.
through a percutaneous means. That would be the only advantage in my mind.
And I've used the fibular nail itself only a handful of times, just like you, Dr. Archdeacon. But I've used long cortical screws, 3-5 cortical screws. You can probably fit 2 of them in the fibula, and they kind of end up intertwining with each other, going up, and that makes a pretty stiff construct. And occasionally I'll use like a pediatric flexible elastic nails, the titanium ones, and kind of mount those up. And they provide a little bit of added stability. I don't think on their own that particular construct is very, very stout, but 2 screws sometimes in the fibula I find to be helpful, especially if you're going to cast them or put some sort of additional stabilization on there. But so this was she did well post-op. She actually healed that wound immediately. She was weight bearing as tolerated right away, and you could see she starts to windshield wipe. You can see that on that lateral image by the calc. You could see the calcus kind of windshield wiping a little bit. And around a year, we decided to take out the rod. Usually I give them about a year or 2. We took out a rod at that point. Then she's been doing well ever since.
And she probably has reasonable ankle motion, doesn't she?
She had reasonable ankle motion even before we took the rod out.
But I mean, I think that's the
Which
other
is great.
thing.
I was like,
Everybody's like, oh my God, you hate the subtalar joint. Why would you sacrifice the subtalar joint? And, what do you do now? You've taken their nail out, you've left this big hole in their ankle. I'm like, they can't feel anything. Their ankle starts moving again. They almost have normal function when the hardware comes out. So I think it's great.
yeah, she didn't have any pain, so. It's not for everybody, but in these types of challenging situations, I think it's a good option.
That's awesome.
That's it for me. Yeah, thanks.
Dr. Ahmed, you're up.
Oh, I can do it from
Yeah, you
here?
can probably do it from
All
here.
right.
I mean, why stand when you can
This-
sit?
uh,
And why sit when you can lie down? That's my motto for life.
What an advancement. So this was a 58-year-old male. He's working at UPS, loading up the truck. He was walking back and forth from the loading dock, and someone drove the truck off while he's walking back and forth. He has a past medical history of diabetes, but that was actually diagnosed while he was in the hospital during his post-op course, as he never really went to the doctor. So he's got this big 8-centimeter open medial wound. And these are standard trauma bay x-rays. What do you guys see?
Badness.
Looks
Yeah.
ugly.
So,
Open
you know,
pilon.
it looks like
It's
only open medially?
yeah. So, you know, it's a really comminuted displaced pilon fracture, big open wound, don't have a picture. And so,
And he's diabetic.
and he's diabetic, but he doesn't know it yet, and neither do I, which is unfortunate. So he got an X-Fix, standard X-Fix, washed it out. Overall, the wound was fairly clean. I was able to close it primarily, and I actually saw a really great fracture line read on that medial cortex with the medial distal tibia. And so I thought it'd be kind of slick and put a little plate under there, because once I closed that medial wound, I never wanted to go back. And so I let him sit and hang out for a while for his next stage. And so that's his post-op CT. You can see the intra-articular portion, it's not too bad. So
Yeah.
what do you guys think from here?
I think you've got sounds like you've got a fairly good debridement on your wound. You got them closed, and it's a fairly simple articular split there, it looks like. So after you sit on it for a while, let the soft tissues calm down, I think you go back and plate that split and get on with life.
All right.
And I think too, I mean, to me, it's really key to talk about the idea of using those open wounds to get some of your joint work done at that initial trip. Because I don't think you pay much of a price for a few mini fragment lag screws and maybe a little plate.
Mm-hmm.
And like you said, that's a wound you never want to go back to.
Right.
And so that's your best opportunity to get an articular reduction for sure.
Do you guys have any thoughts so I think we're in agreement that we'd want to plate it. Do you want to do one plate, two plates? Do you want to do something with the fibula?
You know, this is one I might think about because he's open, soft tissues are terrible, the fibula's kind of a mess, and, this is one I'd consider doing a posterior plating, when I decide to plate him, because I think the soft tissue envelope's better, and you can address the fibula at the same time if you feel like you need to or not, because those posterior plates are pretty stout.
Mm-hmm.
But the idea of doing a separate lateral approach to this fibula in this zone of injury where he's already got a medial wound always makes me a little nervous.
Yeah, no, I agree. That's posterior plate's definitely a great idea. So I took him back. I waited a week and I did an anterolateral plate. I left the fibula since it was so comminuted. I didn't think it would give me much more. I was pretty happy with what I had. I had great articular reduction, good alignment.
Did you stress the fibula as part of it, or was that just kind of like because it was so comminuted you didn't want to necessarily go fixing it?
Yeah, it was so comminuted. I just decided not to, and I thought about putting a screw up it, but then I didn't. It was like, well, is it really going to add to what we're going to do, right? So I didn't let him walk on it for about 2.5 months. Then I let him start walking on it. And then he came back at 4 months and he says, Doc, my ankle turns in a weird place every time I step on it. And he showed me in the office. He's like, look. And he had no pain. And he's like, the ankle kept deviating every time he walked
Great
on it.
motion.
I know,
Just a little
right?
proximal.
Yeah. So,
It's another joint.
right. So now what do you guys think?
And he's not painful.
Not really. I mean, he's unhappy that he can't really walk, right? So
Tempted to leave it alone, but I think you can't. I think you have to do like sort of the first case. You got to make sure it's not an infection, which I'm not saying it is. It's just got diabetic and neuropathic joint. But if it's not an infection, then I think your hardware comes out, and this is probably another area for hindfoot fusion.
mm-hmm. It's not a bad idea.
Although I'd probably be crazy and try to fix it again.
Do you have I would get a CT scan also, obviously, just as part of that workup, just to see how much bone stock you have distally as well.
Yeah, I mean, you could get really push the envelope if all that distal segment is consolidated into one solid piece. Take out your hardware and put a nail down it, right?
The joint's
From
probably
above,
healed.
if not from below. Yeah.
Yeah, and that's also, in hindsight, something that I thought I probably could have considered. So I did my infection labs. His ESR, CRP were elevated. His wounds were all healed. He's walking on it. And so I decided to, and I'm now in board collections.
Oh, of course you are.
I decided, I was like, all right, I don't want anyone to ask me any questions why I left the hardware in or any of that. So I took them all out. I put them in a standard kind of Delta frame. I put antibiotic beads at the fracture site, cultured him, right? And then his cultures came back staph epi. So he got 6 weeks of IV antibiotics. He keeps coming back, all of his wounds healed. His ESR and CRP are still elevated after 6 weeks, and I'm still in board collections, right? So I was like, okay, let's reculture. And I was really unhappy with the amount of valgus he kind of fell back into in my frame, because that's definitely not how I left the OR. And so I was like, okay, we're gonna exchange the beads. I'm gonna put a little mini fragment plate on there. We'll reculture, screw up the fibula, make sure everything's culture negative, and then go from there, right? And so he turned out to be culture negative, and I was like, okay, you know what? I haven't let this guy walk on it. It's been about 5 months since his injury. I want to give him something to let him walk on it right away. So I took out the beads. I did a RIA of the ipsilateral femur, and grafted the bone defect, grafted the fibula defect, and then put him in the Solizarov frame.
Is Spence still here? warm his heart.
So as you can see, I got a ring that's that has control of the distal tibia. I have a whole ring that has control of the entire midfoot and hindfoot, and then 2 rings proximal from this. And so I let him walk on it right away. Waited. Now I can kind of take my time, let it all heal. I took the ring frame off at 5 months after, and he went on to totally heal. So.
That's awesome.
That's a,
Huh? Yeah, I know, right? And then I moved from New Jersey to Orlando.
No, his joint looks great. He's all consolidated. I think, that's, it's kind of the same concept, right, as the hindfoot fusion nail for the high-risk diabetic, right? You're kind of minimizing your potential for hardware complications.
Right.
And, they do a ton of that Charcot reconstructive stuff with frames, so.
But you're torturing yourself with pin tract infections all the time.
You are.
Yeah. He luckily only had 2 infections. I was able to treat them with oral antibiotics. My pin care, I just tell them to do it with some saline, and if they're not able to, if they don't do saline, just use tap water. The whole key to the pin tracks is just get the scab off of it, because once that scab forms, then that's when they get infected.
Well, yeah, and I just tell, the other thing is to tell them just bathe it. Treat it like it's part of your body. Take a shower, bathe your frame, and I'll tell them that 27 times, and they'll still come in like, what, you mean it's okay to get it wet? I'm like, Jesus, I've been telling you that for the last year and a half.
Right, exactly.
No, it looks great. All right, any questions in the audience? I think we actually wrapped up right on time.